You are watching this DVD because you're considering breast reconstruction and have shown an interest in QUEST, a clinical trial studying different types of breast reconstruction. But first of all, what exactly are trials and why are they so important? Clinical trials with patients are the only scientific way to find out if one treatment is better than another, in terms of medical benefits, side effects, or quality of life. Many trials compare different drug treatments for cancer by comparing a newer treatment with a standard one. There have been great advances in breast reconstruction over the last 20 years, and we need to find out more about which types of reconstruction women are happiest with. We already know that the cosmetic outcomes are good, but we need to know how patients feel. So depending on which reconstruction surgery you have, the QUEST trial will attempt to reveal what you think about your quality of life and how you feel both at the time of your reconstruction and for the next 5 years. This trial is the first of its kind, as it's looking at what affects you and gives you the opportunity to tell clinicians how you think and feel about yourself after breast reconstruction. Your valuable contribution will give all clinicians the evidence they need to help them advise future patients about what to expect when they have a breast reconstruction, both in the short and long term. All members of the hospital teams will better understand how to offer the best possible aftercare. None of this can happen without women like you. QUEST will compare one breast reconstruction procedure with another, and the surgeons involved in the trial are all experts in both procedures, so the results of either breast reconstruction will be of equally high standard. We know that the two procedures used in QUEST give similar cosmetic results for the reconstructed breast. However, we don't know if one procedure is different from the other in terms of your quality of life, hence the need for a clinical trial. We also need a balance in the way we select our patients for the trial. This means having similar groups undergoing each type of surgery, so that any differences in quality of life are due only to the type of reconstruction received. If patients or doctors choose which type of reconstruction they prefer, we will end up with an unequal balance of women. If one of these groups fared better than the other, it could be because of the type of reconstruction, or it might be because the women are different. We wouldn't be able to say for definite that the treatment affected the quality of life. In QUEST, a computer program will be used to randomly allocate you to one of the two surgical groups. This will ensure that we end up with an equal balance of women in each group, as represented by the mixture of red and blue figures. So, if one group fares better than the other in terms of their quality of life, it has to be because of the type of breast reconstruction they had. Your treatment will include radiotherapy, but is it better for you to have your reconstruction at the same time as your mastectomy, with chemotherapy if needed, plus radiotherapy coming later? Or is it better for you to have your mastectomy first with a temporary skin expander, followed by your chemotherapy and radiotherapy, and then your final reconstruction? To be able to come to a useful conclusion about this, it's extremely important that enough women agree to take part. You have been asked to take part in QUEST based on your individual needs and physical suitability. You may benefit from taking part, but if you choose not, it won't affect your care in any way. The two breast reconstructions being studied in the QUEST trial both use a flap of muscle plus some tissue from your back to rebuild the breast. This is how it works. The latissimus dorsi, LD, is one of several muscles in your back, under your shoulder blade, that helps to move your arm backwards and forwards. This muscle, together with some fat and an island of back skin, is moved through a skin tunnel in your armpit to the front of your body to make the new breast. The tissue used for the new breast needs a good blood supply, and the advantage of this method is that the original blood supply can be used. There are many other layers of muscle in the back which can take over the work that the latissimus dorsi muscle used to do. The only difference between the two procedures is in the timing. One is an immediate reconstruction. The other is a delayed reconstruction performed in 2 stages. If you are allocated to have the immediate reconstruction, the procedure will be carried out at the same time as your mastectomy. This is called the back flap method, where your new breast will be made entirely from your own back muscle, fat, and more of your back skin to recreate the breast volume. This produces a natural-looking breast that is able to withstand radiotherapy. You will then have your chemotherapy, if required, followed by radiotherapy. If you are allocated to have the stage delayed reconstruction, it'll be carried out in 2 stages. As part of your mastectomy, your breast skin will be preserved by inserting a temporary expander implant, which will be filled with saline over 1 to 3 weeks to fill the implant and stretch the breast skin. You may then have your chemotherapy treatment, followed by radiotherapy. After 6 to 12 months, you will have the second stage of the reconstruction. The saline implant will be removed and your new breast will be reconstructed in the same way as for the immediate reconstruction. Just to remind you, we know from surgeons that both immediate and stage-delayed breast reconstructions give good cosmetic results. What we do not know is how patients cope with having all the treatments occurring one after the other compared to delaying their final reconstruction until after all the other treatments are completed. At the present time, we do not know which procedure leads to a better quality of life.
We don't have any evidence to say we should absolutely do one or the other. When we think about what we're trying to give you and women, and that is a good cosmetic result and a good quality of life, we would say that they are equal, but they both have their side effects. The tissue-only back flap means that we are making or creating a breast using a woman's own back tissue. That means a larger island of skin from the back, which means a longer scar. And it also may mean it's a bit like doing a tummy tuck on the back. There may mean that there are symptoms such as stiffness and the odd ache. And obviously we are very conscious that we control pain in these women. But certainly the majority of women under the program that we have, which is physiotherapy and early exercise and very good pain control, resume normal activities, so that there's no clear evidence that this is not a good operation in the circumstances when radiotherapy is required. So an expander, this is a saline temporary implant that we would use inserted under the chest wall muscle, allow us to save your breast structure and skin envelope, and basically inflate it over about 2 to 3 weeks with salt water or saline, and really therefore just the feeling of tightness and some discomfort whilst we're doing that process, but supported with a sports bra and also maintaining pain control over that time period. Immediate, using your tissue from the back only, making a breast for you at the same time as your mastectomy, allowing you to have radiotherapy. Or the possibility that we don't want radiotherapy effects on the final tissue-only back flap, so we would then propose creating a temporary breast mount for you using an expander implant that stretches the tissues, allows you to have your chemo and radiotherapy, and then your final result, which is not irradiated.